By request of the meeting organizer, this meeting is being recorded.
Happy Friday, and welcome to our MSM of Color Provider Focus Group and activity of the End+Disparities Learning Exchange office hours. I'm Michael Hager. I'm the Manager of Technical Assistance and Dissemination at the National Quality Center, and I'm really excited to welcome you all on today's call to discuss this important issue and to see from our perspective on the provider side of things our experience in serving MSM of color and what we might be able to do to work to improve health equity for all moving forward. We actually have a really small group on the phone today, so I think it would be really cool just to kind of get a little bit of a sense of who we are, and that will actually help us to guide our discussion as we get going as well. I'll start. I'm Michael Hager. I'm with the National Quality Center. I'm the End+Disparities lead. We're located in New York, and I work with grantees all across the country on a number of quality management issues, and I'm excited to be here today with you all to talk about MSM of color health. Chep, I don't know if you'd like to talk a little bit about your background as well, because I think that your background in inpatient setting is really cool and could be instructive as well.
Hi, everybody. I'm Chep, and I'm new to Hub. I've been here about 3 months. I'm a nurse consultant, and I came from the inpatient setting where I did inpatient quality improvements, and I joined the team, and it's been a learning process. So I'm sure if anything comes up that I can apply from the inpatient setting, I'll definitely be willing to chime in. Thank you.
Thanks, Chep. Debbie.
Hi, my name is Debbie Siefer. I am a nurse educator and consultant in HIV and psychiatric or behavioral health issues. And I've been fortunate enough to be consulting and training with all the different Ryan White programs. I work with the Northeast Caribbean AETC, the Southeast AETC, and the North Florida AETC. And I'm about equality and getting rid of health disparities. And I have an extensive history living in the Caribbean. So a lot of my stories, a lot of the work that I do has to do with working with individuals who are HIV positive, living in communities where it's not easy to disclose this information, and thus it is not easy to receive high-level care.
Great. Thanks, Debbie. Dolores.
Hi, everybody. I hope you can all hear me. My name is Dolores Duffy, and I am an NQC coach and the lead consumer for Partner in Plus Care activities in the end+disparities campaign. I'm HIV positive, have been for 23 years, and I've been very active in the arena in different capacities. So I'm really happy to be here and to really lend my voice and my opinions. Thank you.
Thanks, Dolores. Emily.
Hi, everyone. My name is Emily Chen. I am a program fellow here at National Quality Center, and I've been doing a lot of work with Michael on the End+Disparities Learning Exchange, like, making sure events go smoothly, and also been learning a lot from the process as well about what different care looks like for different populations in HIV. So I'm very excited to be here as well and learn more.
Thanks, Emily. Now, I think Gina isn't with us on the phone, so we'll skip over her. Judy.
Hi. I'm Judy Popkin. I'm an NQC coach with facilities in Georgia. And I'm not sure where that noise is coming from, but I don't think it's from me. And I've been involved with the EDLE since its outset, and I think we're doing some really, really great work and sharing a lot of good resources and tools, and I'm very happy to be here and also have some of the folks from my portfolio represented here as well.
Thanks, Judy. And Ms. Dolores, do you mind if I mute your line while the construction's going on there?
No, I just realized it's my heater, so I turned it off.
Oh, okay, cool. Robert, last but not least, my friend.
Oh, okay. I'm Robert Lobo. I've been doing HIV for 26 years. I'm presently at the Community AIDS Network. We have 24 locations, clinics located throughout the state of Florida, and I'm one of Judy's little followers.
Welcome, everyone, and thank you so much for joining us. Now, for those who are listening in to the recording who may not know about this initiative, just some background. The End Disparities Learning Exchange is a 9-month initiative to promote the application of improvement interventions that reduce HIV-related disparities in 4 key subpopulations. And all of this while building and maintaining a community of learners among Ryan-White HIV/AIDS program recipient providers. The Learning Exchange offers a number of informational opportunities to connect folks in different ways. This is an office hours today, which is a very informal discussion, and we hope to be building on the discussion that we had yesterday for our main webinar of the month that focused on MSM of color health. If you haven't had a chance to check out our video, we highly encourage you to do so. It's a great way to feel inspired about working on disparities if you don't already feel very inspired, like I'm sure all of us do, but especially if you're trying to inspire others within your staff or within your set of stakeholders to consider this as an important issue and appropriate for a coming quality improvement project. We definitely recommend that you share this video around and have folks take a look. As I said before, our office hours are informal opportunities to come together to kick around a can and chew on important topics that are very relevant to the work that we're trying to do to end disparities. They're always on Fridays at 1 p.m. Eastern. It's a variable schedule, so we encourage you to check our calendar. We normally populate these about a month or 2 in advance. So you'll see if you go on the calendar now, all of the March stuff is there, and then by the end of next week, we hope to have all of the April office hours posted. Really, this is something that should be, directed by you all as providers and your needs. Debbie is going to help us, kind of walk through this discussion, and then Dolores and I, as staff, will help to guide as well, in addition to Miss Judy. Today's topic is MSM of color and HIV stigma, a provider focus group, and we have a consumer focus group following next week's Partners in Care so that we can try to put together some broader learning on stigma and issues related to care for MSM of color. Now, before we I hand it over to Debbie to kind of walk through some of the discussion. I think that I just want to point out some of the items that stood out to me from yesterday's call, and I want to just kind of, get other people's sense as well. All the speakers spoke about stigma and discrimination as being huge issues, and stigma and discrimination is something that applies on multiple levels when we're talking about MSM of color. We have the legacy of racism in the United States and globally that we're working with. We have heterosexism and homophobia is another thing that we're working with. And then, of course, we have the HIV-related stigmas and identities, which are also, part of this picture. So stigma and discrimination in 3 levels: race, sexual orientation, and HIV status. Another theme that I saw yesterday was access to information, whether or not information is available transparently or whether or not people have to hunt and find it. The level of trust in terms of information that's provided to you, either in writing, electronically, or in person is something else that's, something that's a big problem in terms of disparities that are experienced by MSM of color. The perception that MSM of color have of the medical establishment is pretty negative and relates back in multiple ways to those 3 levels of stigma and discrimination that folks have struggled against and with for decades and or centuries. I think that the main issues for me that I took away were in those categories. Now, I don't know if anyone else who was on the call yesterday had other feelings in terms of themes that are important for us to kind of examine closely on today's call.
So one of the things, this is Dolores, one of the things I also heard was the need for diversity
yes.
among healthcare providers. And I'm not sure that that's something we can solve, but I think it is something that we need to put on the agenda, because I think people really feel that with diverse health care providers, it will address some of the issues that you put forward.
Wonderful. Thanks, Dolores.
Dolores, that's one of, this is, oh, I'm sorry.
Go ahead. I just was going to say that one of the other things that came through, I guess, also was just how long-standing this problem or issue has been, but especially in rural areas, and that's almost, you know, an issue unto itself. And again, the difference in between the age populations and some of the things that they feel communication with the providers done.
Debbie, were you going to chime in as well?
Yeah, it was. Yes. Dolores, I wanted to respond to your comment regarding building capacity among providers who represent different minorities, different racial backgrounds. That is one thing that the AETCs are definitely working on, and much of the money that the AETCs receive for training has to be earmarked for building that capacity among minority providers. And one of the things, though, that I still see is that in these small communities, it's not everybody who can come into a rural community and be comfortable. And so we may gain providers, say, Judy, in the rural communities that are minorities, but it seems that the workforce still has a problem because these individuals may finish their training, then they go back to an area perhaps where they can get some loan repayment, and then after they're there for a couple of years, they leave for either better, a higher paying job, or that their life takes a different path and they choose to leave. So even when we work to build capacity among minority providers, minority care health professionals, they transition as a group quicker, and then the organization loses them after a few years. And so here they've built capacity to treat and care for, and a lot of their patients get very comfortable that there's someone there that they can relate to, and then suddenly in a couple of years after their loans have been repaid or their life has taken personal changes, they leave. And so this is a tough problem you brought up.
Isn't that something that would lead to another issue, or the issue of sustainability of how you make transition when providers are changing, that maybe there's something that we could do to continue the momentum out, you know, depth?
Right, they've used money to do that, and still, you know, it's hard to put money as the incentive, and we would hope that there would be other things that would be incentivizing, and in many cases, when you get the right provider and the right community, and there is a really good match, those individuals stay for the long haul. But that's not that takes a while to build that sustainability.
Yeah.
The National Health Corps has been having this problem for over 3 or 4 decades in retention. But yeah, I was just getting ready to say, and thanks, Debbie, but I was getting ready to say, those that do stay tend to be quality and attached to the communities that they serve. This so happens that my significant other got me to Florida that way, and that to pay back his medical school stuff, it was service in Immokalee or Anchorage, Alaska. So that's how I got to Florida. but that's usually the case, is that those that use the National Health Corps for paying off their loans, that's just what they do it for. I mean, it's the way of getting around that. They've been trying to figure out a way for years. But those that are committed, like Dr. Quero and others that I know that have utilized that, they're committed to the community and HIV when they get involved in HIV.
Right, they become passionate, and I think the other part of this, Robert, too, is not only the core, because that is an entryway. It is a way to get people, providers of different minorities into communities that they may not have ever looked at before, that they might have never considered. But it's also building the capacity and the sustainability once that provider gets there. You know, it's hard to be a champion when you first get anywhere as a new provider or as, you know, a new professional coming into a community where you didn't exist before and no one like you ever existed. But to build a team once you get there, if there was some way to help this new person, this new champion, come in there and build with administration and build within the community a real interprofessional team, then if someone leaves, if the provider leaves, or if another key professional leaves, the team sustains it until they can bring other people in, and then we don't lose people to care.
Well, I think that, you know, and I don't know how extensive AETCs are. I know that with the funding, there was a certain amount of attachment to get minority providers to service minority providers. But I think that if you guys could develop a course that went along with National Health for individuals that have to serve rural areas, and for the most part, the HBCU medical schools, and just focusing on those, that maybe, you know, that will be a way to target minority providers and maybe some sustainability and some interest in HIV.
Right now, the AETCs, just real quick, are in medical schools. They've created HIV comprehensive training programs for students in medical schools that serve minorities, physician assistant programs, and nurse practitioner programs. So there is that happening as we speak. So I'm excited to share that.
Great. Hey, so before we get too much further, I just wanted to take a chance to introduce, or to give Gina the chance to introduce herself. Gina, while you were dialing in, we were collecting some of our thoughts on the themes that we heard in yesterday's webinar, and we also took a chance to kind of introduce each other a little bit to see where it is we're calling from and a little bit what is our driver for participating today.
Oh, yeah, I got the hurricane. Probably the hurricane. I only see.
Gina?
So cute.
Okay. So I think Gina is distracted with something else. I'm going to go ahead and mute her line. Sorry about that, everybody. And, you know, sorry to interrupt you, Debbie, while you were talking. I just wanted to have Gina introduce herself. Great. So, you know, we have a list of items that are important themes for us to discuss. You know, I think one of the things that we were just mentioning is that there are some things that are very much in our control and some things that are much less in our control. The things that are not in our control, there are still ways that we can influence that. And that's the really important news, I think, that Debbie was about to share in terms of the AETC programs and the curriculum that they develop for medical schools. And I think that's definitely one of the major things that, you know, that we can look forward to. I'm wondering, you know, Debbie, as we're walking through some of this stuff, if you have any websites that you want me to look up just to kind of have on the screen here for folks, I'm really happy to do that too.
Oh, okay, wonderful. You know, if you actually go to the National AETC site, you'll see that that is a component that's listed in some of the programs where they are working on building capacity of prescriptive providers specifically, And I know that the Northeast Caribbean AETC has a very strong dental component where they are working to improve the dental care and finding champions throughout the Northeast region as well as in the Caribbean, and that includes Puerto Rico and the U.S. Virgin Islands, to find individuals who in dental that traditionally had never provided HIV care before and building their capacity, because these individuals have been in the islands for a long time. They have made a commitment to practice and to personally live there. So we know that finding folks that have already, like Robert said, committed to living in a community, may not have been sent there, but committed themselves personally and are passionate about the work they do, we have to find those people so that we can say, hey, there's an opportunity, there's a population of people here that don't get a certain type of care, and we want to explore that with you. And that's what a lot of the AETCs are doing on the ground running.
Great. So is this what you were mentioning, Debbie?
Yes.
Okay, great.
Yes. Perfect. You're good at this.
I try.
It's taken me forever. But Duke University's program, I'm actually a Duke alumni. They have a very strong program. It's one of the top graduate programs for nurse practitioners, and SUNY Downstate has an excellent program, and they've got cohorts of students that are running through these programs, and they are evaluating what happens. They're evaluating what happens to these individuals once they graduate. So we've been doing this for some years now, so the data, I think, is becoming very rich in terms of what happens now that these folks get this training, they move or they are sent to a community. How does that work now? How do they become embedded and integrated in the work of HIV treatment and care, and do they stay somewhere?
And is that body of work being captured and written about? Because I'd be fascinated too. Like, I know the SUNY Downstate program very well, and it is extraordinary. You know, and it makes me wonder what opportunities these 5 medical schools have to kind of share their experience with other schools, or is there some group that kind of drives these recommendations nationally that, medical schools should have programs that are like this where people rotate through, or some type of information sharing? How do we spread the awesome work that's happening at these 5 sites?
I think that's a great thing. I think each school, I know, is doing their own evaluations, and then the National Evaluation Center has also been a part of that. But of course, we don't have that up and running right this minute. But each of these programs was tasked when they received funding to develop these programs. They were tasked to follow certain evaluations for it. So that is transparent, and those data sets are available. I know that HRSA requires that because a lot of this is funding from HRSA, but the schools themselves are following those information. So I don't know one place that we can go for it right this minute, but if you're interested and you see a school in this area that's in your region, you could definitely reach out to the school or reach out to that specific AETC, and they would be able to find that for you. Because yes, having that voice, or perhaps asking if you can go and be a speaker or be a site for training. I know that I'm always looking for individuals. For example, I teach at Barry University wearing my AETC hat, and Barry University brings out wonderful physician assistants, and many minorities are represented in these very large classes. There are 3 schools for Barry, one in Tampa, one in Miami Shores, and one in the U.S. Virgin Islands. And I've been invited to speak as part of their infectious disease curriculum, and this will be my 2nd year in doing so, where I talk about the passion that exists in our communities amongst people on this call, for example, the passion that we're just waiting for the right providers to come in to work with us. And, you know, our arms are open. And I've had students call me afterwards and say, hey, where can I volunteer? Where can I go? Because they see the call.
Beautiful. So as far as our building capacity and sustainability of systems and diversity within the workforce, we've talked about the National Health Service Corps, which is individual provider or potential provider drivers, which we have less power over. But one thing we can do is make sure that our service center is on the list to become a National Health Service Corps site. This is going to be especially important for folks in rural areas and underserved urban areas. I think that it would be really great for you to try having a conversation with folks, potentially your project officer, because the National Health Service Corps is actually another part of HRSA, right, Shep?
I believe so, yes, Michael.
So we could find ways to make that happen if it's not apparent to you. I remember Whitney Walker was a National Health Service Corps site, and we had to fill out a little bit of data every year, but the benefit to the organization was huge. So definitely there. The other option is AATC's comprehensive training programs, which we have here. And I really appreciated Debbie's suggestion of reaching out to these centers for more information and to maybe if you are in a medical school setting or have connections within medical schools within your regions, to reach out to them to see what type of learning you can have or an exchange with them, so that, you know, some of their lessons learned you can gain, or some of the insights you have as a certain type of provider gets into their training program. Because on the ground, you may not have a medical school or a need for medical school near you, but of course the lessons you have as an individual HIV provider serving this population could be super important to these programs as far as their training of students goes. I don't know if there's anything else that we want to raise for this topic before we move on to some of the other topics that were discussed yesterday, Debbie.
I don't have anything, but does anyone else have anything burning on this particular topic?
No,
I know for me, the discussion has been very helpful in learning kind of the measures and the steps that are available. I think the only thing is that we need to find a way to get that information out more, that different folks know of the different capacity building opportunities that are available. I know for myself, as a clinic director, I've just started in a new clinic in Newark. And I have reached out to the AETC to see what are some of the capacity building opportunities that exist for somebody like me that works in the community, that look like the community, but I am not a clinician. So, and so when I think about diversity, I am often thinking about diversity across the spectrum for not only clinicians, but other people who have key roles. Working in different facilities. So I'm really, really glad for the discussion and for the information provided.
You know, Dolores, I think that that's a really important point that, you know, as we all very well know, clinicians are only one small part of the service system. In fact, case managers, everybody has a role, you know.
Medical assistants, everybody, right.
Everybody. You know, HRSA recently funded a new project that is at Boston University right now that is looking at community health worker training programs. We're going to be hearing more about this next month when we're talking about African American Latina women, but it's really relevant to almost any population, that the community health worker you know, the closer that community health workers are to peers, the more effective they are. And the community health worker system and training program that they're developing at BU is something that they're going to have prepared for dissemination in a couple of years. So that's something else to kind of keep our eye on in terms of other parts of our service system that aren't just clinicians. This is another resource I talked about a lot already, but especially for those who might be joining us and watching this recording by itself. His Health is an important curriculum that's been developed by NASTAD. I think that this is important for physicians, case managers, navigators, any folks who are trying to have frank conversations with MSM of color about their health, you know. So how do you engage folks about health in a way that's going to be important or meaningful to them, you know? So this curriculum is really going to be helpful in terms of helping folks understand, like, what types of concerns do MSM of color have in terms of their HIV, and how do we raise these competently with them? All right.
That's really helpful. I love this website. It does. What I like about it is it talks about having conversations, those things that really need to happen, and I think that is a great segue into talking about what I thought was just really important that we discussed yesterday, which is the transparency of providers, that building of trust, that relatability that needs to happen. And you don't necessarily have to be from someone's same culture to be able to have a very open, wanting to learn, wanting to help, wanting to partner type of attitude. But I hear every other day terrible experiences that clients and patients are having as they try to access or they try to engage in HIV treatment and care, which saddens me to just no level. I can't say enough on how my heart just hurts when I hear this repeatedly from so many people, consumers, from people that are just walk-ins, people that aren't necessarily consumers of HIV care, but people who watch this happen and allow it to happen. So I have great concern, and I thought that yesterday, that customer service approach, if we have to go back to that, where are we with that? And I know we can influence it. It seems silly that we would have to develop training courses in it, but I guess my question is, what are we willing to do to change this at an organizational level?
I think, well, what Nate was saying yesterday, you know, really hit home to me, is that, and I guess it's because I'm an African-American gay male myself, but it's that sometimes when you try to talk to the structure, the power structure, they don't understand the communities that people live in. I mean, in most minority communities throughout the country, I mean, there are islands of no grocery store islands. There's not grocery stores nor pharmacies that are close by. When I tried to explain to Tallahassee when I was out in LaBelle that the closest CVS was 60 miles away in either direction, you know, it was like they thought I was like pulling their leg. But when you're trying to explain that to the structure, it's like not really. And then when the structure does believe it, it's the condescending or you have it so bad. And, you know, that's a double-edged sword. But I think some development around cultural sensitivity beyond just the whole race, gay, and economic status or whatever, it's that you have to understand that people's living environment plays a huge part.
You're spot on with that, Robert. I think there's creating a culture of community. You know, we talk about various cultures, and you know, everything can be put into a cultural terminology, and exactly food availability, the ability to go to a pharmacy, the ability to go to a dentist that's within reach of your home. I know patients that ride their bike to clinic and it takes them an hour to get there because there is no transportation for them in those communities. It's a culture of caring, not only in an organization, but in an entire community, and all the people that need to continue to work together. I used to live in a very small community in Tennessee, in the mountains of Northeast Tennessee, and we would have our community meetings when I would go to the clinics at this very small community. We would have it at the fire station. And at our meetings at the fire station, we would talk about how people would get food and how people would get medication when they needed it in the middle of the night, and how people would get acute medical attention if they needed it in the middle of the night, because it was 2 hours to get anywhere. Mm-hmm. So it's that culture of community that is very important in our very rural communities, for sure.
Yeah. I mean, one of the things that I think is like I feel a little bit inspired that the AATC network does have a rural health group that's thinking about these issues. And I think that it's run by John Nelson at the National Coordinating Resource Center, and he's an incredibly open guy, big heart and also big thinker in terms of, what types of problems we face and how we might go about solving those problems. And so, if anyone is interested, it sounds like, with your background in Florida, Robert, it might be interesting to kind of patch into that part of the network that is the AATC representative Florida, just to kind of have an interface with him or her and have an understanding of what types of issues specifically are being discussed at these meetings, and how can an agency on the ground help support that work. Because the more that we work together, not just within our communities, but across communities, kind of thinking about the macro picture that Debbie was just painting for us. That might be one of the ways that we can kind of forge ahead as a community in terms of thinking about this. Because we were talking before about, levels of stigma and issues, frankly, I think that the urban thinking, the power centers of this nation are all in cities, and so we're calibrated to be very urban focused, without even thinking about, Tallahassee didn't even consider the fact that you might have to drive 50 miles to get to a CVS because everyone has CVS, duh, and it's that kind of thinking, that we need to tackle here.
Right, it's a thinking problem. It is. That's a great way to put it. Robert, Dr. Jennifer Janelle, the PI for the North Florida AATC, is a rural provider of HIV care and treatment.
Cool.
In the Gainesville area. She's at Palatka. She's in all those outreach areas, and she is on the committee for John Nelson's committee for rural populations. And if you would like, I can get the two of you together. I know she would love to introduce you at a meeting. And she is speaking at the upcoming Big South Conference that Florida and, there's 4 states having it: Mississippi, Atlanta, and Georgia, Florida, and Alabama. And that will be in May. And I would love for everybody on this call to consider going. But Robert, if you don't already know about it, that is happening second week in May, and that will be the 10th through the 12th in Sandestin, Florida. It's called the Big South, and Dr. Janelle will be speaking as a plenary session speaker on rural health initiatives and her work with John Nelson.
Cool.
Yeah, okay, Debbie, you can put me in touch. You have my information, yes?
I do.
My new information, not that?
Yes, you gave it to me when I saw you a couple weeks ago.
Oh, that's right, okay.
I have your card, too.
Fabulous. I just want to take a moment to say hi to NC. NC, I don't know, you've been quiet on the call, and we didn't have a chance to hear from you at the beginning when we were introducing ourselves. Do you want to take a moment to say hi? Oh, just like that, NC is gone. They were like, no calling me, goodbye. All right, so I've learned my lesson. I won't be calling on anyone else.
But Robert, I'll definitely do that. I'll put you in touch with Dr. Janelle. Does anybody else have anything happening within their community or within their organization that is addressing patient experience? We heard some things yesterday that I thought were, you know, hard to hear, but we know it's happening where clients, patients are not feeling welcome, where they walk in and they don't recognize themselves. I'm big about what's happening visually when one walks into a healthcare setting. And if I don't see something that makes me feel comfortable, it makes me look like it's okay for me to be here, then I'm not going to stay probably. But I don't know, are there any campaigns or initiatives going on within this group here?
Debbie, I was just wondering if anybody has replicated like the mystery shopper kind of thing that I know that you've been involved in. Is that a common way to kind of find information, or it has to be sponsored by someone like AETC?
No, it doesn't have to be sponsored. That's something that is a great quality initiative, Judy, that we could even use your quality formatting for someone to do a storyboard on it. It's a simple thing, but you do have to have an okay by the organization that is wanting this, having this mystery shopper, if you will, or mystery consumer come in, because there is the HIPAA and other considerations. For example, what if this person came in and got hurt? Or, you know, those things have to be worked out. Oftentimes there has to be a memo of understanding. In fact, in every situation, I've had to sign HIPAA paperwork, and in one setting, I actually had to go through a training for them, which wasn't a lengthy process, but I needed to do that. And then there was a memo of understanding that what my role would be, or the role of an individual that I might be sending in there to that particular program.
You know, something else I want to add about secret shoppers or any type of, you know, patient experience evaluation, and I think it's about experience evaluation generally, because, I mean, I think the same applies if you were doing staff experience evaluations too, is that ask the questions that you're prepared to have the answer to. It's really important. You know, if we're talking about something like this, that is, it can get uncomfortable. We're talking about racism. We're talking about heterosexism. We're talking about misogyny, you know, probably in some places. We're talking about, you know, stigma with HIV status, another plug for Nightblade's work, you know, from our provider angle. You know, and if you're really, really, really wanting to solve problems, you need to be prepared for the fact that some people might be angry, might not, you know, might not say things in a way that is, you know, politically palatable that you want to publish and put in a newspaper. But, I mean, the idea is that, like, any information and any responses you get, you need to be grounded and be prepared to work with that, because that's the experience of the people that you're asking to share their experience. And I just can't stress that enough, that, like, only ask the questions that you're prepared to know the answer and act on it.
Right. That's a really good point. Very, very important. Going in and receiving, not only doing the actual shopping, but also receiving that information. And I think it's very brave to do that type of thing.
Yes.
Because it's about It's about people. It's not about how nice how fluffy the bed was and whether you liked the pillow top. This is a whole different level.
Yeah.
But maybe I'm just being a stick in the, maybe I'm in a bad mood today. But, no, I mean, the problem with, you know, and Michael talked about satisfaction surveys and even employee satisfaction surveys. Satisfaction surveys that I've seen that we do here in the state of Florida, you know, if I was a patient, all I'm going to do is answer in the most positive light because I don't want to piss off the person that's providing the service to me, whether it's anonymous or not. And when we're talking about doing the shopper thing, you know, that agency that's the most trouble is going to have to admit to letting you in that they have a problem. And that's most of the time not the case.
Yeah, they have problems because they're not mature enough to admit that they have some problems.
They have problems.
Yeah.
Right. Right. And the people that don't want you in won't invite you in. Well, you know, this is also something that funders can do. So, like a Part A program could decide that the agencies that they work with that you know, if it's got close monitoring and they start to see patient experience or satisfaction going down, or they see troublesome issues in some aspect of care in the agencies that provide care that they are paying for, say, again, Part A is as an example, then Part A has not only responsibility, but they also have the power to create a quality improvement program for all of their subrecipients.
Darn tootin'.
And I was, you know, and I guess I've been doing this a long time, but back a couple of agencies ago, when we applied and got minority age initiative money for a Part C, I mean, 51% of the staff in key positions had to be minority. 51% of my board had to be minority. That has, I mean, you know, like you said, Debbie, it's like the funders could, but then, you know, that softened up and the MAI money goes everywhere where it's, except for where it should go.
Right. It's hard because some of the MAI money, you don't exactly, the definition of what that is, I have found over the years that I've worked in ATC since those monies have become available. It's, everybody sort of defines that a little bit differently. There is no real, I think, strong definition, and I'm wondering if that is something that we need to have a lot of input on what that really looks like and what, how do we find it.
Initially, when those monies became available, it was very strong language out of the Congressional Black Caucus as to where and how that money was to be spent. But then over the years, it's gotten watered down, and the definition has gotten.
And now it's not recognizable on some level.
No, it's not.
And if you were to canvass a lot of different programs that are funded by the MAI funds, you would see that they're all doing something different.
Exactly.
So we're definitely on a similar page. But, you know, even the Part C programs could get together and decide, hey, we're not going to just pick any parts, just one Part C or two Part Cs in Florida and two Part Cs here. We could do an initiative that involved all Part C programs that look at the patient experience and how do you build that level of transparency and team approach to care that is welcoming, that is non-judgmental, that reduces unconscious biases, which are hugely prevalent in all areas, not rural areas, not just urban, they're everywhere. I mean, right now I'm living in downtown Fort Lauderdale, right next to the federal courthouse. And even though there's such a mix of wonderful ethnicities here, there's still a lot of bias. There's still a lot of judgment.
So this is Dolores. I know in New Jersey, it took a while, but we were able to get the Department of Health to support an initiative, which is a survey that's delivered to people living with HIV to other people living with HIV, trying to assess their the stigma that they experience in accessing services or as they deal with HIV disease. And it's called the People Living with HIV Stigma Index. It's a tool that was developed by the Global Network of People Living with HIV and the international community of women living with HIV, and it's used globally. But it was great that we were able to get a rollout in the U.S., and a few states have taken on the project, and I'm very happy to say that I've been involved with the project in New Jersey. And the survey is ongoing currently, so there's no data to report, but I really think that when we get to that point, it will be interesting to see what people are saying. And the questions really ask you to talk about stigma that you've experienced in the last 2 years. I think all of us who are living with HIV a long time could talk about stigma going all the way back. But it would be interesting to see what has been happening in the last 2 years since we've learned so much about HIV and whether or not the knowledge is translated in our provider setting and in our community. So when that data is available, I'd be happy to share it with you all.
That would be wonderful, Dolores. Thank you for reminding us that that is happening and, as you said, rolling out in some of the states as an initiative. I would like to also see this kind of thing roll out in professional schools where we have an opportunity to really get into the heads and hearts of individuals who are going through health education to become providers, to become professionals on the interprofessional team, if you will, and helping them identify those maybe unconscious biases or the stigma that they too may be carrying around with them, because that does affect us, and dealing with it early in your career before you go out and you take on the responsibility of caring for others. It would be a good time to learn about stigma and the effects of stigma and unconscious bias, and that how it affects our actions and our practices.
In this project, the Roots of Health and Equity, I've mentioned a couple times, but is, I think, a great way to start that discussion. It does, dive into some of the social determinants of health and talks about institutional racism and misogyny, and talks about a lot of the things that contribute to the health outcomes landscape that we're all a part of today. And I think is a really wonderful place to kind of see where your staff is regarding these issues. If you're seeing people who are denying that these are problems, then that tells you something about where you're at. And I think that, if we kind of think about this, in terms of, well, what steps can I take? I would say that this course might be one of the first steps that I would take, because it's kind of, let's talk about this. We're going to, examine some, specific stuff and talk generally about stuff. And from there, I would say that moving into a stigma assessment of your staff and a staff-driven stigma assessment process is a really, really great idea. And after that, you could potentially, you know, start to think about how, you know, your staff can be very supportive and promote, you know, people living with HIV to initiate this process. You know, if I was to think about 3 steps, I would probably like lay them out that way. I don't know, Debbie or others on the line, if you have a reaction to that, but I'm just trying to think in terms of takeaway, what's the first thing, what can I do by next Tuesday as someone on this call?
Does anyone have a thought on that? I know I do, but I don't want to take over the conversation if someone is being quiet and wants to really have a moment to share. Well, being that I'm not hearing any volunteers, I would say that a first step, I'm very good with silence. I work in behavioral health, but I would just say to you that I like that first step approach. The AETCs are involved not only with practice transformation right now, but they've been also directed by HRSA to work on interprofessional education within each of the units. And this, I have been engaged in North Florida in working at the University of Florida and promoting this care or this training on how we provide interprofessional education. And I did a program on stigma, but it was interesting. We needed to start with the faculty who were teaching it, and to be perfectly honest, people were reticent to complete a questionnaire because they didn't know where those data would go.
Oh, fascinating.
And I thought that was really interesting. So if we can't do it with our faculty and it's not safe, then is it safe? Will our students be feeling safe? And as a faculty member, I'm not going to have my students do something that I'm not comfortable with. So you see where there are challenges. But I love the fact that, you know, some learning has to be personal too. Yeah. And I love the possibility of maybe somehow working this actual training into the interprofessional education for the next year. We're just coming off our first year, and it's been an experiment. You know, no one knew exactly how to do it, didn't know what the response would be, but starting with a new cohort, it seems like it would be a great place to start.
Well, great. All right, the time is now 2:03, and we did get started a little bit late, but I don't want to go too much later. I just wanted to thank all of you for participating in today's call and sharing some of your background and sharing some of your thoughts on this as providers and how we can all work to achieve health equity for all. So thank you very much for your time today, and thank you so much, Debbie, for helping us to shepherd us through the talk. Very, very grateful for that.
Thank you. Love being on the call and love hearing everyone's voice today, and looking forward to opportunities to discuss and maybe put that first step together. You know, sometimes we have to do it in little pockets of learning like the one we have today. Thank you for the opportunity to be together.
Cheers. Bye, everyone. Have a wonderful weekend.
Bye. Thank you.
Take care. Bye-bye.
Bye.
Bye.